module is going to look at the workforce structure of the health service industry. Now, the health service industry is one of the fastest growing industries in the United States across the board compared to all other industries and currently employs about 13% of the labor force. Now, when we think about health services and healthcare, we generally tend to think of physicians and nurses, but the workforce expands and extends far beyond that into several different types of professions. So throughout this video, while we will focus on physicians and nurses because they do make up the majority of the workforce, we are going to look at some other types of professions that exist within the workforce structure. Now, while healthcare is the fastest growing industry, when you compare it to all other industries, healthcare is one of the only industries that steadily grew jobs and increased jobs while all other industries were losing jobs across the board. And this is really great for those thinking about entering into the health service workforce because that means more bedside positions are going to be added and needed. So that really benefits those who are considering a clinical profession, such as a nurse, something in allied health, like a respiratory therapist, a lab tech, a physician, but that also means that we're going to need more people to run these healthcare industries. So we're going to need more administrators, we're going to need more managers, we're going to need more people working in supply chain, we're going to need more people working in IT. So it goes far beyond the bounds of what we traditionally think of healthcare and health service. We can start pulling in professions from other industries such as IT, such as logistics, into the healthcare workforce structure. Now, there are three main reasons that we see such a dramatic growth in the healthcare sector across the board. That can mainly be attributed to one, our growth in population from our immigration, two, the aging of our population overall. And what I mean by aging is we have several different generations separated out by years. And right now we see the majority of our baby boomer population, one of our largest population segments, starting to retire. So as they start to retire, positions and jobs are going to start opening up in the workforce, but in particular to healthcare, those population segments of the baby boomers are going to need people to take care of them. So that's going to open up more positions and more opportunities for those wanting to go into the healthcare workforce. And then, of course, the expansion of health insurance under the Affordable Care Act. Now that we're opening up access to primary care, each individual is required to have health insurance. We're going to start seeing a greater utilization of healthcare services across the board. Now, we have several ways that the healthcare workforce is comprised, and it's comprised of many different types of workers. So we have three or four main segments. We have our clinical segment, our clinical support segment, our allied health and administration, but we do still remain very physician-centric. We covered this throughout the foundation of U.S. healthcare system, why we remain physician-centric and why we started out physician-centric. Now, we can think of clinical more like along the lines of our nursing, clinical support, more CNAs, certified nursing assistants, patient care technicians, positions such as that, and then allied health more along the lines of respiratory therapists, radiology, and radiology technicians, and positions such as that. But do note that while we are comprised of several different types of workers across the board for healthcare workforce, we do remain very physician-centric. So since we do kind of still have this physician centricity component to our workforce, let's first focus on physicians overall. Now, mainly when you go to the hospital, your first point of contact with the healthcare system, in or outside of the hospital rather, is going to be the physician. We see about 80% of physicians are more office-based and 20% are more hospital-based. Now, when we have physicians that are hospital-based, that 20%, we call those types of physicians hospitalists. The 80% that are office-based, run or own or operate their own practice outside of a hospital and then have rights and privileges to come in and either see patients in the hospital that are patients of their practice or conduct surgery in that hospital. And those are the 80% that operate and own an office-based office outside the hospital system, with the remaining 20% being hospital-based, and again, we call those types hospitalists. Now, overall, physicians are responsible for and account for about 20% of personal expenditures for our healthcare system. But either directly or indirectly, physicians are going to control about 75% of the amount that is spent on healthcare service expenditures. Now, we attribute that to either directly, like I said, or indirectly, because directly they'll offer treatment or provide treatment to a patient, but indirectly they'll give admissions, referrals, order lab tests, order different types of x-rays, CT scans. So either indirectly or directly, physicians are going to be responsible across the board for about 75% of the amount of money that's spent on healthcare, while they provide 20% of the personnel expenditures for the system. So a small segment of the system overall that controls a large segment of the expenditures that we see when it comes to spending for healthcare. Now, across the United States, we have roughly around 905,000 physicians that are active across the United States. We see them mainly concentrated in areas like California, Texas. We have a large concentration of Florida, and then we have a large concentration in several states up in the Northeast, including Massachusetts, New York, Pennsylvania, Ohio, and Illinois. Now, the other states we see fairly even spread, especially your more Midwestern states. We see the total active physicians range from about 591 to 12,000. And then where you start to see these larger states that are more population dense is where we start to see physician numbers from 27,000, almost 28,000 to upwards of 48, 49,000 physicians for that state. So think back to our discussion during the foundations of our healthcare system when we talked about physicians and kind of their rise to prominence and how the American Medical Association affected that. Remember, the American Medical Association came into being to protect the interests of the physicians, so it really pushed for medical education reform. Now, if you'll recall, how they did push for medical education reform was through something called the Flexner Report. In 1910, William Flexner, again, was commissioned by the American Medical Association to go out, survey all existing schools of medicine, and really work to create standards around medical education, mainly in terms of who gets admitted and what types of courses should be offered. Now, after the report came out, any schools that were not at that level of set standard that William Flexner put forth in that report were cut essentially as places where you could receive medical education. And if you'll remember, unfortunately, the majority of those schools that were cut were attended primarily by women and minorities. But that Flexner report really worked to help firmly establish physicians as the centerpiece of our workforce and our healthcare workforce. And that's why we generally tend to think of a physician or a doctor when we think of healthcare. Now, in terms of education, we have two types of degrees that physicians can obtain. You can get a Doctor of Medicine, which is an MD, which is what most people are probably familiar with. Or you can have a DO, which is a Doctor of Osteopathic Medicine. Now, both of these degrees do need to come from some type of accredited medical school. The difference between the two both MDs and DOs, medical doctors and doctors of osteopathic medicine, both use traditionally accepted methods of treatment, including drugs and surgery. But we see osteopathic medicine, which is practiced by those holding DO degrees, really works to emphasize more musculoskeletal system issues, looking more towards things, for example, such as correction of joint tissues. Now, MDs or doctors of medicine, they're trained in allopathic medicine, and that views medical treatment more along the lines of an active intervention to kind of produce a counteracting reaction to neutralize the effects of a certain type of disease function that they're looking at. So both practice methods of treatment, both use drug therapy and surgery, but the ways that they go about it are just a little bit different between both of them. Now, in terms of education for physicians, there is a 4-year period where they have study, they go to class, they do a lot of book work, they graduate from medical school, and then they come out and have to do a residency program that can last anywhere between 3 and 7 years, depending on what type of practice you're going to go into or what type of specialty that you're going to practice. Now, a generalist or a primary care physician is going to be a physician that practices mainly, as it says, primary care. They're going to work with the family, they're going to work with internal medicine, or they're going to work more with pediatrics. Now, the second type of physician that you can have, aside from a generalist or primary care, is going to be a specialist. So these are going to be anybody that's an OBGYN, for an example, obstetrics, a physician that's a radiologist, a surgeon, anyone that has to go get some type of board certification in an area of specialty. That's going to be your specialist physician. So again, there's two categories: your generalist that works more along the lines of primary care, internal medicine, and then your specialist, things like your OBGYN, your radiologists, and your surgeons. Now, if nothing else, we know that medical school is very, very costly. On average, when we look at financing education for medical school for physicians, it's going to cost somewhere between $250,000 to upwards of $350,000, and that's just the average. Now, depending on what school you go to, that could be more along the lines of $400,000, $500,000 to go to medical school. Which unfortunately has a negative impact on those entering the workforce, and why we're seeing a shortage of physicians, which we'll get into a little bit later throughout the video. But one of the main reasons is that the education in school is so costly that a lot of people just simply cannot afford it. So we see the government start to intervene here, and start to help with the financing aspect of medical education to kind of alleviate some of the pressures and the financial obligations for those really wanting to go to medical school and to become physicians. The government gets involved to the tune of about $11.5 billion a year through different types of programs and residency programs. One of those programs is called Graduate Medical Education Funding, or you may hear it called GME for short. Now, GME has two separate aspects to it. You have a direct component and an indirect component that go along with the GME funding for medical education. Now, the direct component is the residency program and residency training. So we only have so many slots across the country that can be filled by physicians, and GME opens up those positions and those slots across the country for graduating students to fill when they need to do their residency. GME also pays residents a certain amount of stipend a year and a percentage of a supervisory salary a year, to about an average of about $50,000 a year, is what they're paying to physicians who start out in their residency program who are receiving GME funding. Now, the other aspect of GME funding, the indirect aspect and how it's involved in the financing of healthcare or in the financing of education for physicians, is that GME gives a subsidy to hospital training program costs. So, hospitals that are teaching hospitals where physicians have residency and practice, they get to have patients that may have longer inpatient stays. They may allow for more lab work simply because these are teaching hospitals and physicians need to learn how to become physicians. So it may require longer inpatient stays or more labs. And graduate medical education, or GME, will give an indirect subsidy to the hospital for those types of training costs. But overall, when you put it all together, on average, GME gives out about around $100,000 per year per resident that is involved with GME funding. So $100,000 between salary and different types of training. Now, GME, like we just said, is a public funding of physician education. So that means public money, your tax dollars are going to pay to fund this program for physicians. And it's coming under a lot of increased scrutiny over the years. But we want to ask, why is that? Why is a program like this that's supposed to help alleviate the cost of medical education for those wanting to enter that type of field, why is that becoming under such scrutiny across the board with the public? Well, I want to challenge you to first think about, what do we know about physicians and the distribution of physicians across the United States? And what do we know about where we are more likely to find physicians, in more urban areas or more rural areas? Um, we overall are seeing a lack of physicians in rural and underserved areas. Most physicians migrate towards larger cities to practice, and that's leaving these more rural and these more underserved areas at a huge disadvantage. So when we really look back over the last couple of years, what we're seeing is um, a, a decrease in the amount of primary care physicians, or an unequal amount of primary care physicians versus specialty physicians that exist out in the workforce. And there's quite a large gap there. And this really goes back to an earlier lecture when we talked about the supply of physicians in the United States versus other countries. So we see in other countries a 3-to-1 ratio in the United States of specialties to general practice, where in other countries we see a 1-to-3 ratio of specialty to general, meaning that in the United States, for every 3 specialty physicians we see, and remember, 3 specialty being OBGYNs, radiologists, surgeons, for every 3 of those, we only have 1 primary care physician. Where in other countries that may put a little more emphasis on primary care, for every 1 specialty physician, so every 1 OBGYN, every 1 radiologist, we see 3 specialty physicians. And this is something that's really unique to the United States. We don't really see this in other industrialized countries across the world, this ratio shift. We see this primarily in the United States, where we have a 3-to-1 ratio of specialties to general practitioners. So when we really start to dig into it and look at it, our costs are mainly higher in the United States as compared to other countries because of our high number of specialty physicians to general practitioners. Unfortunately, our primary care physician has become more of a case manager role because everybody wants to go to a specialist. If I break my leg, I want to go to a surgeon or an orthopedist. I don't want to go to my primary care physician. I want to go to somebody who specializes in fixing broken bones. Um, so so again, we see this unique ratio to the United States compared to other countries where we have about 32 to roughly about 39% of our physician workforce is primary care, and roughly about 60% is specialty care. And in other countries, we see that flip-flopped, particularly over in Europe, where they have a 1-to-3 ratio in specialty versus general practitioners. So when we further start to break this down and continue to look at the differences between primary care versus specialty care, um, we can generally think along the timeline of how you enter the healthcare system. So your primary care physician is usually your first point of contact, and that primary care physician may act as what we call a gatekeeper, who gives you a referral out to a specialty physician, um, and that specialty care results from that initial primary care contact. So primary care has become more of primary care physicians have become more of a coordinator and a manager of care, and this is going to become really relevant when we talk about managed care organizations. Uh, but specialty and specialty physicians focus more on intensive patient conditions, not so much primary care and the management of care. So while we understand that our supply of physicians and how physicians are supplied and what the ratios are and how the workforce is looking, supply of physicians is one thing, but our distribution is an entirely different issue. And this goes back to why we were talking about why GME comes under such scrutiny. It's the way that physicians are distributed across the nation. So when we look at a map of the United States, we can see something called the health professional shortage area, mainly concentrated in the South, out in parts of the Northwest, some parts of the Southwest, but mainly concentrated right there in the Southeastern region. We don't see it so much up in the northern, the northern part of the country. Now, if we look in particular at our state, at Tennessee, and kind of pick out the Northeast region where we're located, we can see a lot of our counties that surround us fall into this healthcare professional shortage area. So these counties are really designated shortage areas. They're typically going to be more rural and poorer areas because we see the distribution of practitioners going more towards urban areas. Now, why is that? There's a couple reasons that physicians may migrate more towards those more urban areas versus our more rural areas. And there's a couple challenges associated with really recruiting physicians to these rural and underserved areas. So, they have longer hours with generally lower pay than what they can make in more urbanized areas, bigger cities. Think, places like Houston, New York City, Nashville, Washington, D.C. All those places, physicians are able to make a lot more money than what they can in a rural or underserved area setting. Now, generally, again, with rural and underserved areas, we have reduced access to technology. People like to say that they're behind the times. And while that may be somewhat true, it's another point of contention to try and recruit physicians, or creates another challenge to try and recruit physicians to these rural areas. And then the quality of life. Some people do not feel that, not everybody loves a rural community setting. Some people like the big city and bright lights, and not everybody wants to live in small town USA. It can be challenging to really work to recruit physicians to these areas. Now, the expansion of the ACA also creates another challenge, or another compounding issue for why we're starting to see the projected gap in the number of primary care physicians across the country. Now, the demand for primary care is increasing due to the ACA because everybody has access now, and it's putting more strain on the system, but we're not seeing enough physicians go into the workforce to accommodate for the amount of demand. So the supply and the demand are imbalanced with each other. We don't have as many physicians going into the workforce as what's needed to keep up with the demand. So we're expecting this shortage to really intensify through 2025. And as we get closer to that date, we start seeing a greater and greater shortage of physicians in the system, particularly with primary care physicians. Now, if you think why this might be, think about the differences between primary care and specialty care. Um, I would go in, primary care generally tends to make less money than you would at specialty care. If you're going to medical school, you're self-financing the first 4 years of medical school on your own. Now, GME will come in and finance years 5 through 7, but you come out of school with about $350,000 on average in debt. So, if you're going to school for that long, to it may make sense to go ahead and be a specialty type physician so you can make more money, pay down that debt quicker, and get a better return on your investment. So why are we seeing such a gap or such a shortage of physicians overall in the U.S. healthcare system? So we see, again, go back to the gap that we anticipate through 2025, how we expect the shortage to intensify, um, mainly due to more people are now able to access healthcare, which is great, and more people have access to insurance, but in turn they're creating more demand on the system, and so the gap and the need are becoming larger and larger, and we start to see them kind of splinter apart from each other instead of staying in line. But the supply, and a couple reasons why it's more difficult to address the supply, is the long training time. So you're thinking at least 7 years, 5 to 7 years at minimum of graduate education, and then depending on if you want to specialize, it could be a very long time that you're in school before you really come out and start to make a living and bring in an income. So it does take a significant investment in your time. These long training times can last upwards of 7+ years. So to help with this supply issue that we see and the difficulties that we have to address it, we have a couple policy levers to help address those different types of shortages. Now, the first one is called the NHSC, that's the National Health Service Corps. The National Health Service Corps think of it more like a student repayment program. So the NHSC says if you'll come work in a rural area and stay here for X amount of years, it may be 2, it may be 5, it may be 10, the NHSC will pay off all of your loans for medical school. So a lot of people are drawn to NHSC simply because they devote X amount of years of working in a rural area in exchange for having all of their student debt, remember up to $350,000 repaid. Now, the only drawback here is, like it says, NHSC will send you to more rural areas because of the distribution of physicians we saw across the United States. We see them more concentrated in more urban areas. Some people may not take advantage of NHSC simply because they do not want to go live in that rural area setting. So another policy lever we have is called the J-1 visa program. Now, J-1 visas in the United States, this is really used as sort of a release valve, and you can think of it as a release valve. So when demand on the system, on our healthcare system, gets more intense or gets worse, the United States government will issue more J-1 visas to offset that demand and increase the supply of physicians. So J-1 visas are issued to foreign trained physicians to come over to the United States and practice medicine. And that's how the J-1 visa really works as that release valve to help take some pressure off the system. So we have a larger demand, we're seeing a decrease in supply of physicians, so we can anticipate a lot more J-1 visas being issued and a lot more foreign trained physicians starting to work in our workforce, in the healthcare workforce. And then again, GME, which we've already covered, opens up additional residency slots in more of our rural and underserved areas. But again, if you're not wanting to or willing to go work in a rural area for a set amount of time, you may not take advantage of some of these programs like NHSC or GME. Now, as we move out of talking about physicians, we'll move to more of our next main component that we think of when we think of healthcare, and that's our mid-level practitioners. These are going to be positions like your family nurse practitioners and your physician's assistants. So after physicians, the next thing we think about are nurse practitioners, physicians, and then nurses. For mid-level practitioners, you can have something called an APN, that's an advanced practice nurse, and these are going to be positions like your nurse practitioner and your midwives. And they're along with physician assistants, their primary purpose is to fill in the gaps in primary care, particularly where we see the most underserved, and that tends to be in our rural and poor areas across the country. Now, their practice settings are split out amongst 4 different types of categories. About 44% of mid-levels we see in group practice. We have about 8% that practice in something called FQHCs, which are federally qualified health centers. We have about 24 that practice in the hospital setting, and then we have about 12%, a smaller percent, that are able to practice independently or solo without being under the direction of a physician. Now, unfortunately, GME, while it's offered for physicians, it is not offered for mid-level providers. Another reason that it does come under scrutiny. So there's a lot of advocates out there that are really pushing to have GME opened up for mid-level providers to bring more people into that particular profession, because a lot of people may want to go be physicians, but they are not able to finance years 0 through 4 of their education, but they may be able to come in and finance their education with the help of GME, becoming a nurse practitioner or a physician's assistant. So as of right now, GME is not offered to our mid-level providers, but there are a lot of advocates out there that do kind of lobby and push for GME to be offered to our mid-levels, for nothing else, to help offset the pressures that we see on the system right now. Now, the way we see mid-level providers distributed across the country, we see 3 different types of categories. So we see areas of the country where mid-level practitioners must practice under a physician to prescribe, diagnose, and treat. So they have to work directly under a physician. They need physician involvement. We see smaller sectors of the country where physician involvement is needed to prescribe, so the physician has to sign off essentially on the prescription for a patient, but mid-levels, your nurse practitioners and your physician assistants, are able to operate semi-independently in terms of diagnosing or treating patients. And then we see another sector of the country, and they're all kind of grouped right there together, where nurse practitioners and physician assistants, your mid-levels, can practice completely independently of a physician. They don't need any type of physician involvement to diagnose, prescribe, or treat patients. So 3 different types, the first being the most restrictive, where you have to work directly under a physician and they have to sign off on prescriptions, diagnoses, and treatments. A second, smaller sector, where physicians do need to sign off on any type of prescriptions, but nurse practitioners and physician assistants can diagnose or treat independently. And then the last sector across the country that we see kind of grouped there together, where mid-levels can practice completely independently in terms of diagnosis, treatment, and prescribing. Now, next to physicians, when you think of healthcare, you think of our workforce, you naturally are going to think of nurses. And that is very true because they do make up the largest group of healthcare professionals in our workforce. So mainly made up of registered nurses. who can have two different types of classifications. You can have a registered nurse that has an associate's degree or a registered nurse that has a bachelor's degree. The difference between those is associate degree being 2 years, bachelor's degree a little bit more intensive training, particularly along the management realm, and they receive a 4-year degree. And then you can also have advanced practice nurses. We mainly see these in types of classifications like your clinical nurse specialists, your nurse anesthetists, your nurse practitioners, your nurse midwives. Um, and then aside from your registered nurses and your advanced practice nurses, we also have our licensed practical nurses or our LPNs, and then our certified nursing assistants or our CNAs. Now, our supply and demand of the nursing workforce is almost cyclical. So we were more recently we saw more of a shortage in nursing workforce, and there's really a surge and a decrease depending on what's going on in the economy at the time. So, think back to how our system is set up. We have one of the only market-based systems across the world. Um, and as such, the workforce is really subject to the ebb and flow of the economy. So again, more recently, we see a shortage of nurses in the workforce, and this is really in response to the changes we've seen in the economy. We're coming out of a recession. People are not able to afford to go to school. We also have the baby boomer generation retiring, so we have a large sector of nurses that during the time we saw a boom into the nursing profession. Now all those nurses are at retirement age and they're starting to out-migrate and retire from the profession. And then simply, geography, just like our physicians, we see nurses almost unevenly distributed across the country. But we see that demand in nurses, generally the increase is due to more people are living longer, we're having sicker patients, and they're requiring more intensive care. And then we also are seeing a growth in more alternative settings. So we see nurses going into case management, into quality assurance, prevention, utilization reviews. So they're going outside the bounds of what we traditionally think a nurse, what we think of a nurse as, and going into more of these, what we call alternative settings. Now, when we think about, let's go back a minute to the geography piece of the supply and demand of nurses. Now, when we think about geography, think about particular areas of the country where you may be located in a certain area where you have 7 or 8 schools of nursing that surround you. That geographical location, you need to think about the implications that it really has on your market supply. So we may have 8 schools of nursing that surround us, and not to mention the LPN and the CNA programs. So we're essentially flooding our own marketplace with nurses, with LPNs, with CNAs, and you have to think the economic impact that might have on salaries, on quality of care, on younger generations out migrating from this area and going to more urbanized areas. So it's all cyclical and all related when we talk about supply and demand of the nursing profession. Now, as we did with our mid-levels, we're going to look at the different types of practice settings where we see nurses. Of course, you can already surmise that we're going to see the majority of nurses, about 63% in that hospital setting is where we find most nurses working. We'll find some in ambulatory care. We'll find some in public or community health, more of the health department setting. We'll see some that migrate more towards home health. We do have some that come back to academia because somebody has to be here to teach nurses how to be nurses. And then we do see a percentage going towards nursing home, extended care, LTC facilities, end-of-life care. And then we have a small sector that may go to other types of settings outside what we traditionally think of the workforce of nurses. Now, aside from nurses, I said earlier that when we think of healthcare, we generally tend to think of nurses and physicians, but we have all other types of professions that encompass our health service workforce. A couple of these I want to point out are professions like a dentist, which uh, diagnose and treat any kind of issues that you may have with your teeth, anything to do with your mouth. We have pharmacists who work in also a variety of settings. We have dispensaries, we have compounding pharmacies, we have your standard like Walgreens and CVS setups, but we also have pharmacists who work in the hospital. Some other workforce professions to note are chiropractors, which are starting to become a more popular method of treatment. Our eye doctors, our optometrists, and our ophthalmologists. And then more along the lines of our mental health facilities and mental health practitioners when we talk about psychologists and psychiatrists. I'll focus again in relation to the dentist and pharmacists, chiropractors that we just talked about. We need to also include components of the allied health workforce. They're really the support for our clinical workforce, and they're a huge asset to any organization and to our whole workforce structure overall. So we're going to see these more in our tech or support positions. So we're going to have positions like your surgical techs, your cardiovascular techs. You have people who do your diagnostics, like take your x-rays, take your CT scans. We have pharmacy technicians, medical assistants, emergency medical technicians. And really, when you step back and think about it, comparatively to your nursing workforce, your physician workforce, your mid-level workforce, we usually see a better return on investment or ROI when we consider the amount of education that goes into training. So you can go and take a 6 to 8 week course and become a pharmacy technician. Now for Tennessee, when we look late last year, when we look at the income for pharmacy technicians, you'll go to Memphis where the median income for pharmacy technicians is around $30,000. And the range is usually between 28 to 35, which may sound on the lower end, but consider a pharmacy technician certification course at your local university may cost $400 to $500. That's not a bad return on your investment for a $400 to $500 investment. Now let's look at emergency medical technicians. Again, in Memphis, we see EMTs making about $32,000, $33,000, and their range is usually between $30,000 to $38,000. Again, not a bad investment or not a bad return on a very somewhat small investment. So don't discount the allied health workforce. They really are the backbone and a really large supportive piece of our overall healthcare workforce. Now, one of the last professions that I'll talk about is health administration. We have to have somebody run the business of hospitals, of health systems, of health departments, of every kind of sector of the health workforce, and that's mainly done by health administrators. So as healthcare is becoming more complex, there's more to do, we have an increasing demand, we're going to need more administrators to run our different facilities and our different programs. Now, these are going to be people that are trained healthcare managers and business-minded, business-oriented people. They've got a background, foundational knowledge in healthcare management, and they use business aspects and principles to go out and run different aspects of our workforce. And we really find these at all levels throughout our organization. Next to nurses, it is probably one of the largest portions of our labor force is the health administration. And we'll find health administrators, like I said, at all levels of an organization and at different types of practice settings. So when you think of health administrators, you generally tend to think of them serving in a hospital, which is true, but we also see them in clinics, we see them in nursing homes, long-term care facilities, we can see them in community health centers, health departments, we see them in academia, um, we see them at local health departments. So they're pretty ubiquitous wherever you go within the healthcare workforce realm. Now, a lot of their major responsibilities are to run programs and departments. They've been trained in management, they've been trained in business principles, so we see them making decisions for strategic planning and marketing. We see them integrated into finance and accounting management. We even see them on the operational aspect and the clinical aspect. So you'll have many of your clinical practitioners, like your nurses, your mid levels, even your physicians, that'll go back and become healthcare administrators and then run clinical and operations management for a hospital, a health system, a clinic, whatever the setting may be. And healthcare administrators also look at efficiency and effectiveness of program, and most recently, there's been a large trend in population health management with which healthcare administrators are starting to integrate and get involved in. Now, this is becoming increasingly important as we continue to move through our new era of healthcare reform, because there's been a larger portion or a larger spotlight placed on population health management. Now, like your other types of professions that you see in the workforce, there is a progression for those wanting to go into health administration. Um, and you can stop really at any point along this continuum, but you start with your undergraduate degree. You get a bachelor's of science in health administration and healthcare management and health services. There's a variety of different undergraduate degrees that you can achieve and obtain. Then you move on to your graduate degree. So you can get an MPH, which is more a Master of Public Health, which has a healthcare administration component, but it is more public health focused. You can get a master's in health administration, an MHA. Of course, that's going to be more hospital management focused. And then you can also get an MBA, a master's of business administration, that's going to be more business focused. So just depending on what career track you want to follow really dictates what type of graduate degree you would receive. So you can stop there at that progression, or you can go on and get a degree, a doctoral degree, something like your DRPH in health administration. That's going to be more of your applied, practice-based doctoral degree, or you can get a PhD. So that's going to be more research, academic oriented if you want to come back to academia and teach. So I hope throughout this video you were able to learn just a little bit more about the healthcare workforce, a couple of professions that we generally tend to think of and maybe some that we don't, and a couple of the struggles, issues, and challenges that we see as a workforce. While it is a very uh, growth industry and we see it growing overall, the challenges that come along with our supply of physicians, supply of our more clinical positions, and starts to get you thinking about different ways that we can kind of work to start addressing some of those issues that we're starting to see. So we're going to go ahead and stop the video here. Thanks for joining.